thanks for inviting me today. Very nice to see familiar faces in the room. So my background is acute medicine and being a patient on occasion, a carer for loved ones who've come into contact with healthcare conditions and obviously the pathways involved. And I do a bit of work on the national and the regional side as well. So for a long time, deterioration has really been one of the reasons I get out of bed and come to work. And for me, it represents that slippery slope in the middle. It represents the acute, usually unexpected, worsening of physical health that usually has to happen before someone dies. So if we think about the pathway of wellness to death, we come across initially our stable baseline, which is what we are like day to day. We have some sort of insult, some condition that comes along that knocks us for six. And then the process of deterioration that's involved. And then, unfortunately, in some cases, a cardiac arrest and death. And for me, in a simplistic level, this is what happens when people die. And this is what the physiological deterioration pathway looks like. And we know that in more than 90% of cases, a change in physiology is the key thing that changes, that we could monitor and we can pick up. There will always be a small proportion of urgent and very sudden vascular events or neurological events that cannot be predicted, but the vast majority can be. And this is the ballpark for this talk. And when we think about what that insult might be, it is literally everything and anything that can cause any sort of degree of physical harm. And instead of being condition specific and blinkered to only one or two conditions like sepsis, for instance, this is about keeping a very open mind and thinking about what the true possible causes of deterioration are and what the early warnings are that we can pick up and do something about it might be. And if we think about, I guess, the nerve and the reflex arm that is the classic model for deterioration, the recognition being the reflex hitting itself and then the response being the motor action, we can start to sort of get to a schematic of what that might look like on a local patient level from a systems perspective and what we do day to day in terms of as leaders and potentially the things we need to do to intervene to make things better. I.e., we're a room full of leaders in this room, and we need to have our finger in the pulse of what's happening in each one of our organisations in the dead of night, at the weekend, when our most junior staff are exposed to the most critically unwell patients in each one of our organisations. And it's really understanding that on a base level as leaders and actually doing the deep dive to understand the way our organisations really perform when the lights are out. 9 to 5 is 40 hours of the working week out of a significant more that are covered by a more skeleton staff. So it's about systems. And if we do a thematic analysis, and I'm not going to go into this in great detail because John Welch is following me, who will do this much better, but we do find some common themes within deterioration, namely that communication, orientation, the language that's used in healthcare, hierarchies of care, the availability of information, and the continuity and handover are recurring RCA themes. And that we know within all-cause deterioration, which is probably 65% of all avoidable death, that this is our big opportunity. It's the low-hanging fruit. A recent, very interesting report from HSIB detailed a lady who came in who was 58 years old with abdominal pain, having previously been discharged the week before. She was seen in the emergency department and then was passed through the hands of some medical and surgical teams. Certain tests were ordered, some tests were not. And at every stage and at every handover, there was an erosion of information and a palpable lack of standardization between the language used to describe and the language to assess a patient, right from the front door all the way through to the back door. On repeated occasions, we didn't escalate the care in this particular lady's case, and she remained with a very disordered physiology for some time. And there were all sorts of learning points from what we saw. And I have to say, conflict of interest, I'm a specialist advisor to HSIB, but I thought the merits of the case were very strong and certainly occur in my organisation and a lot of the organisations I look at. The key factors for me were around these classic human factors elements that happen everywhere. What's great about HSIB is that because they are safety experts and independent, We get a different lens on the view of our incidents that are happening day to day and probably plague us for some time. And it's important to recognise that we are human beings, and that element of diagnostic foreshadowing which occurred throughout this case, and I do implore you to read it, is something that I know pervades healthcare at every level. And the other, I think, really important point was how important judgment and worry and concern of our healthcare professionals really is, because that's the heartbeat of when we escalate care. We don't randomly discover people that are sick and deteriorating. People tell us when they're sick, they signal us, and then we do the set of obs, and then we realise they're really unwell. So it's how we train people to do that. When should I be worried? When should I escalate? What's my permission for taking things to the next step? Certain Trump organisations, my own included, think they've got deterioration solved and sorted, and it takes a warts and all junior doctor audit to look at what really happens so you can get under the skin of deterioration truly. And what you realise when you start looking at the 7 new patients that deteriorate in ward environments is that we're not always that good at documenting what happens. And we're certainly not always good at escalating, communicating, and responding to those patients in a timely fashion. In this particular example, less than 50% of cases were not responded to, so more than 50% were and documented about. But 50-50 is pretty bad for conditions that have a 50% 30-day mortality. I think we'd agree. And it's worth looking at your own organisation as a result. So as a result of this and the support of many in this room, we have been pushing for years for incentivification, and hallelujah, it's happening from April. The wards deterioration sequence to increase the reliability of documentation of significantly ill patients who deteriorate in ward areas. We're not after a score. We're not after a reliability element of timeliness of response at the moment. We're merely after some documentation that someone has noted a deterioration has happened and someone has responded to it and they've used News 2. It's really basic stuff to begin with. And that's the right place we should begin with, because believe me, our beginning point is we don't know and we don't document reliably. So let's start from this point and then improve from there. And then it'll be up to us in our organisations to take this data and do something about it. To use the £500,000 plus per year to sustainably invest in deterioration and the care of really sick people who deteriorate in the out-of-hours time periods on our wards. This is our opportunity. And it sets a blueprint for, I guess, what we could look at in future sequence. And what I'd really like us to evolve towards as a country is thinking about those interfaces more consistently and more properly. So start with the documentation. How are we doing? What do we need to improve? Use the resources we have. We have case mix auditors in every intensive care who can take this data down and submit about 100 cases per quarter. And let's see how we're doing. Use it for research as well. Use this opportunity to see where we are really doing and be honest with ourselves and where we would like to be in the future. From a bare bones perspective, the bit that's really missing from this is what nurse worry is. And John and I have had many conversations about this, together with various other very senior nurses. And I hope we can explore what nurse worry really means properly and start getting it out in the open. What is it we really want to train people to observe and note? Because that's our base barometer of all. It's not going to be a news score. It's about what a nurse feels, gut feel-wise, what a patient says, and how our clinicians respond. This is a great form from Portsmouth that looks at similar. So a deteriorating patient performer, very simple, very standardised, will be sequence compliant, and it's going to be on the RCP website pretty soon, I hope, and NHS England and Improvement. It's also on the National Deterioration Forum as well, so you can download it all. I will go into that in a sec. But essentially what's really good about it is that it records your basic stuff and important stuff about resus status as well and how far you're going. The second arm of national improvement incentives that are coming along is the rapid standard that's going to be looking in all emergency departments. So the idea of this is how can we incentivise and prioritise the care of the critically unwell? We are going from potentially a flow target to one that focuses on those who are critically unwell without forgetting the need to properly ensure that there is flow of patients from the front door to the back. So what this is about is using the evidence, looking at what news scores do and what that predicts at triage. So as soon as you hit 5, you're at 8% mortality, just from coming in through the door with an ED with any emergency problem. If you leave ED with a referral with a news score of 5, your mortality goes up to 18% within 30 days. That's why we've settled on those scores. And are thinking about urgent assessments therein. So each one of you, think about this in the future. Think about your organisations and what you can do to support this at the front door. The care of the critically unwell is so important. I'm sure we'll all agree. And it's about the language we use to translate that to politicians, to the media, to the general public, and also our colleagues. Because for years we've had a mantra of certain targets that haven't always, fitted well with what we feel as healthcare professionals. This is about the most sick, and that's where we're coming from with this standard. But it's not going to stop there, because we know the data supports this idea, and particularly if you don't correct the observations, your mortality really rises. What we need to think about is what the improvement is in mortality and avoidable harm if we actually use it interfaces of care. And that 1, 2, and 3 day data is really interesting. If we can cut our mortality just by using the same language of sickness across 40,000 patients in this study, then we will really start to see some differences in general practice, in ambulances, and across all interfaces of care in hospitals. And that's the dream. That's where we need to be aiming for. I haven't published it yet, but I will. So essentially, this is a couple of site study that shows, again, that importance of using the same language at referral points. These are referral points from the ED to all inpatient specialties. And what you see is quite a massive reduction in the mortality rate just from using the news. 20,000 patient study. Powerful stuff. And when you look at it from general practice, it shows what a lot of us have always felt, that actually vital signs don't lie across whatever environment you're in. They predict who's going to die. Not absolutely, but they're a good signal. It was great to see the RCGP statement from yesterday that acknowledges this finally, that we are in this space where vital signs are encouraged at referral points, at assessments across the whole care pathway. We are not there yet with news in general practice. We haven't published enough about it, and I don't blame them for stating what they have stated. But interestingly, the vote against mandatory implementation of news across the whole of general practice went from 9-1 against to 6-4 against inside a year, because they know the evidence is coming. We will get there. I have no doubt about that. And we have this opportunity for an evolving model towards a safer medical take as a result, from pen and paper, moving on to something that's more electronic, with templates for referral encapsulating a news score when a GP sees a patient, electronically transferred to a hospital take list and an ambulance conveyance list, so we can get through the stack and get to the most sick most urgently, using standardization of referral forms digitally that I hope we will implement widespread now, that will pull the data from GP systems, from EMIS and System 1, and mean that the red boxes are the only thing a busy GP or a community colleague needs to fill in, the rest of it being auto-calculated. And as soon as we get to that, we can start thinking about standardizing the way we work across a whole region and a whole system to ensure that we do the same thing in every single hospital, in every single general practice, in every single ambulance, in every single district nurse visit, every single mental health interaction where there might be physical health issues. And think about this as far as all conditions go. Don't separate what doesn't need to be separated. And think about generalism and multi-morbidity and holistic care. And when we did this in our region, we started thinking about what that would influence in terms of where we locate patients and how urgently we see them, and thinking about ambulatory care clinics versus ED resus versus the medical admissions unit or the surgical assessment unit. And we can stop cardiac arrest from happening just from doing this, simply because the right sort of patient goes to the right environment. There are things that are within our gift, but we need to talk to our colleagues across the whole care pathway and use the academic health science network and patient safety collaborative networks that exist in our regions. This is about regionalised care. It's not about central command and conquer. It's got to be about the regions. And we've set this forum up that you're welcome to join. Ping me an email. But essentially, deterioration leads from around the country, and there are 400 now, who basically have an obsession with trying to reduce avoidable death, meet and talk and discuss electronically on this forum from an NHS perspective to try and improve the system, to share and network, to share resources. And this is where all the stuff about the sequin is. And what's interesting, if you're into it, is the strategy behind it all and how it evolved from being a conversation on a forum to suddenly becoming a national incentive. And that's the power of electronic forums. Don't dismiss them. And we can leap even higher if we start interacting properly at a regional level. So we formed a regional forum for each one of the 15 regions with a view to giving the capacity so that if you want to start your conversation in a region, you can do. We have a number of patients who are a member of this forum as well. So our opportunity now is not only to use, I guess, what we have and our best practice, but start to thinking about things from a bigger perspective, the future. Where does that lie in terms of digital information, artificial intelligence, machine learning? And we start with the basics. Start with patients, start with clinicians, and what is the best methods of getting the information they need into their hands at really ridiculous time periods when no one is available to get the old notes, when you're doing a home visit at 3 o'clock in the morning to a nursing home when no one knows the patient. How are we going to ensure the safety of our patients through information? And then apply that information into analysis, to doing machine learning, to research, and then completely reimagine the pathways of care they're in and innovate around them, and then apply what there can be applied from artificial intelligence. This is a model that could go everywhere, and it should go everywhere. And the question is whether, I suppose there's enough will in the room to make it happen in each one of the regions you represent. And soon, perhaps, we will arrive at this nirvana where suddenly all that information is available for direct patient-facing care at all times of day in all environments and improve the safety of our patients everywhere. Thank you.